so today I have the pleasure of having Marjorie and Chuck. Marjorie is a nurse anesthesiologist, PhD. She's a program director of the Nursing Anesthesia Office at Hopkins University. And Chuck is a cardiothoracic surgeon. So together they have many, many years of extensive experience working in the medical field, specifically in surgery and in teams, which is going to be the focus of our discussion today. So welcome, Marjorie and Chuck.
Thank you.
All right, so you know what, I'd like to start out, if you could share anything else about your background, just tell us what it is that your work entails.
Okay, great. So I was a nurse for 5 years, and I went back to school to be a nurse anesthesiologist. Trained at Charity Hospital in New Orleans, so it was very interesting to train there. And over the years, when I graduated, I specialized in cardiac anesthesia and worked for this for Chuck for about 10 years before I went into education. And like I said, currently I am the program director of the nurse anesthesia program at Hopkins, but I've been in education for about 20 years, but I maintained cardiac practice probably until about 5 to 10 years ago. But yeah. So.
And I'm a retired cardiac surgeon. I practiced for about 30 years in New Orleans in a private practice setting. Before that, I'd done my training and residency in general surgery in the Chicago area. I think I had a pretty successful and happy career for the 30 years that I was in New Orleans. And I was fortunate to work in an environment which supported my practice, allowed me to do the best that I could do, and allowed me to be a member of a team that was very precise, practiced, supportive, and allowed me to really have a pleasurable career.
All right, wow, it's just so cool to hear you talk about your experience. If you could say, many of us are not that familiar with the medical field and how surgery works, where do different players come in, where someone like a nurse anesthesiologist would come in. Can you kind of help us understand a little bit? I think it will help us get a better sense when we get into the team dynamics discussion.
Sure. So with the nurse anesthesiology or anesthesiology in general, we work with our physician counterparts, physician anesthesiologists, or we work separate, independently. But basically, we meet with our patients before surgery. We learn all about your comorbidities, what your illnesses are, why are you in the hospital, what are you allergic to? Because we have to plan what kind of medications we're going to give to you. We also work with our surgeon because we want to know what type of surgery, about how long it's going to be. So we are planning on not only the anesthetic, but how are we going to manage your vital signs while the doctor is operating. So we are focusing on the full body, the vital signs. We're making sure that you're breathing, your blood pressure is fine, etc. So that's what we do. We put you to sleep for the surgery, wake you up at the end. We manage your pain. We're pain specialists as well, so we manage pain. But basically our job is to keep the patient comfortable during surgery and pain-free so that the surgeon can operate on somebody without having them move or in pain. So, and then afterwards we'll keep an eye on the patient for about an hour, 2 hours. If you're in the hospital overnight, we'll go ahead and check on you every day, follow up and make sure that you didn't have any problems with anesthesia.
Okay, and that's more than I thought was within your role.
Yeah, the typical patient begins their preparation about 6 o'clock in the morning when the anesthesiology team arrives and assesses the patient and places the monitors and intravenous lines and various devices that they are going to need to monitor the patient during the time of surgery. So they generally do that between 6:45. We roll into the operating room at 7 o'clock. I'm standing at the patient's bedside on the operating table as the anesthesiology team induces the general anesthetic. Prep, drape, cut skin at 7:30. Cardiac surgery is a fairly mature specialty at this point. By that I mean all the tricks have been worked out. It is something that is pretty routine, pretty formalized. We know what works. We know how to obtain the results that we want to get, so that it lends itself to being something that's repeated on a daily basis or a case by case by case. Everybody's a little different in terms of their cardiac anatomy, but what we are doing to take care of it in the operating room is pretty formalized. So in a typical heart surgery, there's the surgeon on one side of the table, an assistant across the table. In my situation, it was usually a nurse who was either in my employee or had worked with me for a long, long time, so very familiar with my moves. At the head of the table is the anesthesiology team, and perhaps an MD anesthesiologist, mostly the nurse anesthetist who's monitoring throughout the case. Over there is the perfusionist, the person who's going to run the heart-lung machine during the operation, which will support the function of the heart and the body. Over here is a scrub tech, over there is a second scrub tech, and back there is a circulating nurse who is going to make sure that, you know, there's anything we need at the operating table, it's available for us. The gift I was given in my career is that I had people who chose to work with me for 20 plus years. The person who stood across the table from me, the nurse, had done hundreds of cases with me. The scrub techs were also well practiced, very familiar with my technique, and that becomes important because heart surgery is a very time-sensitive procedure. During the operation, we typically are supporting the function of the heart using a machine called the heart-lung machine, which is circulating blood, drawing it out of the body, circulating it, putting oxygen in it, heating it or cooling the blood as we depend, and then sending that back through another tube into the body, so that the machine is taking over the function of the heart, so that during the time that the heart is actually being operated on, we can stop it, isolate it from the circulation. There's no blood flowing into the heart now. There's no oxygen going into the heart. We infuse it with medication called cardioplegia, which electrically stops the heart, stops the metabolism, and so we're working on a quiet, non-beating heart. But you can only be in that condition for a certain length of time before you begin to see structural and functional deterioration in the heart. And we think generally about 3 hours is the maximum that you can be on the heart-lung machine before you see things start to go downhill. So the operation has to proceed very smoothly, quickly, and accurately. And that's where having a practice team comes in. The scrub tech is the one who's going to, when I put my hand out and say, I need a 7-0 proline, that's the suture we use for some of the parts of the operation. He or she already has that prepared. put in the specific needle holder that I like so that it can come up. And they're also thinking 1 or 2 steps ahead. Okay, he's going to tie a knot, someone's going to have to cut it. He's already asking for the scissors across the table. So that a practice team allows you to smoothly perform the operation accurately without wasting any time. You don't want to be in a position where you say, I need this now, and they say, oh, not in the room, we have to go get it down the hall, because we're wasting time.
Yeah.
And you just can't have that. So a practice team is vital to some degree. It shaves time off the operation. But the thing that is also recognized is that there's one captain of the team, and that is the surgeon who is doing the operation. And virtually every decision that is made in that room is ultimately made by the surgeon. It's my responsibility. I'm the guy who went and evaluated the patient and asked him permission, signed the paper to do that operation. So it's my responsibility. And even though this nurse has been working with me for 10 years, she's been here for 20. At the head of the table, the anesthesiologists have been there 10 plus years. At times, it's still very lonely. There are some things that solely the surgeon's responsibility, and you're the only one who can make that decision. For example, on a mitral valve replacement, mitral valve is in the center of the heart, between the chamber which is draining blood from the lungs and then going to the chamber which pumps blood out to the rest of the body. Mitral valve is in the center of the heart, very hard to see sometimes. You're operating through an incision down here in the middle, but that valve is way down here. The stitch in the 2 o'clock position is sometimes really hard to get. And I often would say, sometimes jokingly, I've just made a hole in the heart that I don't think I can close. But ultimately, I had to close it. I had to throw that stitch. Sometimes it was really tough, especially if there's a lot of calcium deposits around the valve. It's in a difficult position to see. I could look around the room and everybody is, trying to help as much as they can, but ultimately, I'm the guy who has to throw that stitch, and it has to be perfect.
Yeah.
So that even though I've got a team around me that is practiced, suddenly it shrinks down to me. I'm by myself, and there's no one else who can do it.
Yeah.
Something else that's really important in teamwork is communication. Because I do closed claims research and malpractice research, and one of the things that we see ultimately is a lack of communication. And with the team that I was part of with Chuck, we had very good communication. It got to the point where it was like hand signals and eye signals. So
Yeah.
it was just really that well oiled. And when you have a machine like that, and I believe, over at Shock Trauma, they're very similar too, because they have such a small area that they work in, and they're all, the same people, small group of people, they work together all the time. And it's so important to have that precision when you're doing a trauma, because you don't have time to say, hey, what do you want me to do? Everybody's expected to do something, and you should know what your position is and what you're supposed to do. I worked at the trauma center in New Orleans, and so that's another precision team along with a heart team. I mean, all surgeries are teams, but some take a little bit more precision and more. You have to know your role, and it's very important if you're having somebody that codes. everybody has to know somebody is going to do the respiration, somebody's going to do the chest compression, somebody's going to give medications, somebody's going to write everything. So it's a team, and everybody has to do their part to make things flow better and for the safety of the patient and to document what you've done.
Yeah, it sounds like really very complex and so many moving pieces, and every piece, if one piece doesn't do their job, doesn't move correctly, that could really hold people back.
And then when you leave the operating room, you go over to the intensive care unit, and the nurses take care of the patient in the intensive care unit. And here again, it's, the sense of teamwork is necessary, because the surgeon can't be at the bedside for the next 6 days. There's time when you have to go home. There's time when you have other cases to do. So you are dependent on someone who is experienced to take care of that patient for you during really the most unstable time. Is the immediate post-operative period. And so again, having an experienced team is very helpful in that situation. There are some, and the way patients are monitored nowadays, there's a lot of objective data that comes in. Pressure here, pressure there, how much oxygen, what's the temperature, this blood count, that blood count. We get a lot of objective information. But sometimes there's also the situation where in the middle of the night, I would get a phone call and the nurse would say, I don't know what's going on. I'm not quite sure that there, what is causing this. There's just something funny going on with this patient. I knew, based on my having worked with that nurse for years, that if she said there's something going on, I don't understand it, I got out of bed, got in the car, drove to the hospital.
And I was one of those nurses. I will never forget, and I've told people, I would tell him, I said, I can't figure it out. But usually by the time he got to the hospital, the patient was about ready to crash, and we were right on top of it. So it's really important, with that communication, and that he listened. He understood and trusted his team.
Yeah. And how does this communication develop? Is it just over time you get used to it, or is that something specific that was done to encourage it?
Well, it is encouraged, but I think it takes time, because especially as a new nurse, nurses are intimidated by the physicians. So Chuck has never been one to really intimidate. He's always been very helpful and welcoming, but you learn because it's about the patient safety. So you learn to communicate, but it's not everybody's able to do it, and even seasoned nurses may still be a little shy with their communication. But when you really put it into perspective, this is for the patient's safety, and it's a team, then you realize he's a captain, he's my teammate, we can work together.
But the thing that has to be developed is, as I said, we've got a ton of objective data. We're monitoring the blood pressure every beat of the heart. We're monitoring the pressure inside of the heart. We're monitoring the heart rhythm. We're checking the blood counts, all the blood chemistries. So we can try and make our interpretation of what's going on easier by a ton of objective data. But again, there's that sort of sixth sense that is very valuable to have a trust in that individual who is at the bedside when you're at home. And when you get the call that says, I don't know here are the numbers, but there's still something that I don't understand going on here. That sort of sixth sense has to be, it's either a gift or developed through experience.
So it it sounds that in addition to the experience, there's trust that goes into it, there's comfort, right? Maybe some doctors maybe are a little bit more intimidating, nurses, other workers may not want to speak up, and also maybe a little bit of that element of trust in yourself and the courage, if I understood that correct. Okay.
Yeah.
All right. What do you feel? When things go right, what are the things that contribute to it? And I will ask the second question with it together because I imagine they may go hand in hand. When something goes wrong, what is typically the culprit?
So I would say when things go well, we're working as a team and we're all doing what we're supposed to do. And if something goes wrong, our first inkling is like somebody didn't do their part of that. One team member may not have done what they were supposed to do, but then sometimes things just happen despite everybody doing the right thing. And so, but I would say, sometimes you might want to look at, was there a team member that didn't do what they were supposed to do, and that may have caused the outcome, the poor outcome.
I would argue that as a surgeon, if anything goes wrong, it's the surgeon's fault. It was always my fault. Either because, one, I didn't evaluate the patient preoperatively well enough, which I don't think I ever missed on that, or, I made a bad move or a bad decision, or, I took someone to surgery when the operative mortality was prohibitively high. But surgeons tend to always take the responsibility. Simply as a captain of the ship, it was always my call. And things, as Margie said, things don't sometimes work out as you had planned or hoped or prayed, but ultimately, I would take that responsibility.
Sounds like pretty challenging.
It is.
Not just from a technical, but also from a spiritual perspective.
Well, it also, as I mentioned earlier, it can be very, very lonely. Many a night, the intensive care unit was over here. I had a little office right next to it in which was a couch. And during heart surgery, patients are given blood thinning medications so that while they're on the support of the heart-lung machine, the blood can't clot anywhere in the body. At the end of the operation, you want the blood to clot so the patient doesn't bleed. But sometimes patients do bleed after the operation. And there are two major causes for that. One is a technical problem. You left a hole someplace or a stitch tore someplace, or what I call medical bleeding. The patient just will not clot the blood, and you have to give them blood clotting factors, platelets, other medications to try and correct that coagulation profile so that they can clot the blood. But many a night, I would spend sleeping essentially next to the patient in the intensive care unit in my office as I monitored their bleeding. And I would go every 15 minutes, get up, walk over, look at how much has come out of the drainage tubes in that 15 minutes, mark it down, back and forth, every 15 minutes, sometimes for hours on end. And it was my decision. There was no one I could call to say, what should I do with this? It was my decision. Do I give this? Do I give that? Do I take them back to the operating room? My personal criteria, for example, is if they bled more than 400 cc's in an hour, I took them back to the operating room to make sure that there wasn't a little stitch that I missed, to make sure that there wasn't a surgical clause of cause of the bleeding that I could correct with one stitch. Vast majority of the time was not that case. We were very careful before we left the operating room to make sure that there was no surgical bleeding. It was just the patient's blood wasn't clotting. But to rule out that one slim chance that there was, a stitch that was missed someplace, when they bled 400 cc's an hour, they went back to the operating room. And again, I labored over that decision. It's the middle of the night, I'm tired, I got a full day tomorrow, I've had 2 or 3 cases this day. It's 2 a.m., put out 100 cc's the last 15 minutes. Do I call the OR team in and say, we got to take them back now? It's a very lonely decision to have to make.
Yeah.
And it had to be the right decision, because if you let the blood accumulate around the heart, if it doesn't come out the drainage tubes, that blood can interfere with the heart function, keeps the heart from being able to expand and then subsequently contract. So there is some risk about not correcting bleeding. If you have to give the blood products, the blood transfusions, well, there's the risk of all the bad stuff, the hepatitis, the AIDS, the transfusion reactions. So you wanted to limit that too. Yeah, there were some lonely times.
Do you think that loneliness can be managed, helped somehow, or is that just part of what the job is?
It's part of what the job is. Part of what the job is. And I'm sure that's the same for every buddy who is trying to do a good job and who takes responsibility for their work.
Yeah.
Sometimes you just have to be the one to make the decision. And even though you have a supportive team around you, and there's no question in my mind, I felt more comfortable if Lacey or Bobby Knox was standing here. They relaxed me a little bit. They were experienced, been with me for years. If Felix was across the table from me, it relaxed me a little bit. So, again, having that team there is comforting to some degree, but ultimately, if you're the leader of the team, you take the responsibility.
And that goes for anesthesia as well, because we're making the decision of which medications to give for the patient. And if we give something that maybe didn't turn out the way that we had anticipated, again, you still feel that responsibility. So for the anesthesia, but again, the whole team, like I've always worked in a team with an physician anesthesiologist. So, we would collaborate on what was going on. If I had questions or, kind of like something's going on here, and I've tried everything I can, and usually I'd call them in and they didn't have anything else to offer, but it was nice to have someone to kind of back and forth collaborate with. So, yeah.
Let me ask you, from what have been the most challenging times that related to teams that created a problem during the operation?
Well, I'm not. Yeah, I would say a different team. Probably having a surgeon come in a bad mood, yelling at everybody, throwing things, being disrespectful. That hurts the team, so then it throws everybody off, and it's hard to work together when you're afraid somebody's yelling at you or throwing something at you. So I would say a disruptive attitude by anybody, whether it's the surgeon or a circulator or even one of my colleagues, that is very disruptive to the team if you have somebody that is being disruptive. So.
Yeah, but I think those days, thankfully, have largely slipped away. I mean, the prima donnas don't exist to the degree that they used to. But yeah, I mean, inexperience, can be annoying. It can be annoying.
Or team members who think they know more than they really do and try to do things that they shouldn't, so that's,
Overstepping their role.
yes, that is disruptive as well, and it hurts the whole team, so.
Chuck, I think when we were talking earlier, you gave an example of a nurse who sounds like was a little bit overstepping her role, if I remember correctly. Can you talk a little bit about the impact that it had?
Yeah, that was an unusual occurrence, I will say. But this was someone who'd had prior experience with other heart surgeons in other hospitals. And while she was very knowledgeable and her assessments were usually correct, when someone is not doing well in the post-operative period and I'm standing at the bedside, I'm running through my mind the different scenarios of what can be going on. What labs do I need to help me decide how to make the next step? What medications should I be giving to try and support the heart function a little bit better? What's the next step? And what you have to be aware of is that when you initiate one of these steps, the result is not instantaneous. You have to sometimes give the medications a chance to work. And so if I say, okay, I'm going to have to start this medication to support the blood pressure and the heart function, so we'll start that. I'm already thinking in the back of my mind, if that medication doesn't work, this is going to be the next one that I try. But I'm going to give enough time to determine whether that medication works. This was an annoying situation in which the nurse came up to me and said, well, don't you think we should start this now? And yeah, I agree. That's going to be my next thing, but I want to take this first.
Yeah.
And after doing that 2 or 3 times, I finally had to say, listen, I appreciate what you're doing, but I'm captain of this ship.
Yeah.
And, I appreciate, and again, sometimes I would be in a position of having to make a decision that was counterintuitive, perhaps, but needed to be acted on immediately, without any question,
Yeah.
without any debate, without any discussion. Mm-hmm. And the vast majority of times, people would do that, both because they respected me, they knew my results, they knew what I was doing, they'd been there for a while, or because there's sort of certain pecking order in the organization, and if this guy makes the decision, you do it. If you want to debate it, you can do that later, but you're going to do what needs to be done right now. So that was a very unusual situation. I would say maybe once or twice in my career, I had someone who was difficult or unpleasant to work with.
And unnecessary distraction too. Because now you have to deal with them as opposed to just
That's
thinking
exactly
about
right.
the
That's
patient.
exactly right. And while you trust their competence, in order to work in an intensive care unit, a nurse has already usually had several years experience. They're specialized in their experience and training. Those who work in a heart unit have another step of experience. So usually they're pretty sound in their judgments and pretty knowledgeable. So it's not that the debate is based on discrepancy in the knowledge.
Yeah.
I mean, both of us know what, okay, the pH of the blood is 7.1. What are we going to do? We're going to give bicarb. I'm calculating it in my mind. We both know that. There's no debate over what that patient is going to need within the next 15 to 20 minutes. But, it's my decision to give that. Maybe I have something else going on. Yeah, I'd like to give bicarb, but I'm worried about the potassium and the glucose. If I give this, it's going to change that. So I may be thinking 2 or 3 steps ahead of someone else and looking at it from a little bit further back. And so there could be a little bit of conflict there. But again, it was very rare. Most people, if they're doing something as challenging as heart surgery, one, they're doing it because it's just flat out fun.
Yeah.
It's you're at the top of your game.
Yeah.
It's just flat out fun thing to do. So most people who are doing that, it's their choice to be there. It's a specialized unit. It's a specialized team in the OR. I had one hospital where we didn't do a lot of heart surgery, maybe 100 cases a year in this one hospital. But there was one nurse anesthetist who wanted to do each and every one of them. And he made it a case that if it was on the weekend, it was on the night, if it was on a night that he wasn't on call, he wanted to be called and come in. And he wanted to do that case. And I always used to joke, when I walked in the operating room and saw them, I'd say, I've got the steady hand of Dave Shaver at the helm. Because he chose to come in, even on his days off.
Oh, really?
Because it was fun. He wanted to do it.
Yeah. Oh, that's great. So it sounds like process, roles, communication is really critical, and I imagine that the more challenging the situation, the more time sensitive, if it's an emergency, those become even more important.
Yes, absolutely.
What about you, Marjorie? Do you have it from your perspective? Do you have any challenges or stories to share with us? It's okay if you don't.
Yeah, I can't think of any right off the bat. So I've had people who do anesthesia. We love what we do, like the heart surgeons. It's a great career and it's exciting. There are times in our career that can be a little bit boring, but for the most part, it's just a wonderful career. So, I think that if there have been some bad times, it probably has gone off and, I don't remember them. I just remember what an awesome, field this is and career it is.
And so we talked about the importance of process and everyone knowing their roles, but what about when people are first starting out? Whether it's when you were first starting out, Chuck, or when new people sometimes need to come in, how do they go from being just kind of a person who received the basic training to getting in sync with that particular team?
You have to be patient, right?
Yeah,
patient.
in my particular case, to become a heart surgeon, you first have to be a general surgeon.
Yeah.
So you do medical school, then you do 5 years of training to become board certified in general surgery. Then you do another 2 or 3 years of specialized cardiac training. So after 8 years of residency, I still wasn't a polished heart surgeon. I was just starting out. And the gift I was given is that I worked with someone who was incredibly talented, one of the early pioneers in heart surgery, and always thinking of new ways of doing things, developed a lot of the techniques, developed a lot of the equipment, and it was a true apprenticeship to some degree. So I really believe that when you're starting out, you need to have someone who's better than you
Yeah.
ahead of you.
Mm-hmm.
That probably applies to everything. I mean, no one just walks into the operating room and says, here's my certificate. It says I can run the heart-lung machine. No, you're going to sit with the guy who's been doing it for me for, years and learn how to do this and make sure that you're safe. We can always learn a little something.
Yeah.
So the key is to have someone who's better than you lead the way for a while.
It's mentorship, yeah. So we have, in anesthesia, you have to be a critical care nurse for about 2 years before you go into 3 years of additional training. And then when you get out, we graduate students who can go into practice right away. But generally, hospitals will have some type of orientation and mentorship. And so you have to be patient with a new team, but also be willing to mentor them. I would have students come with me to learn how to do cardiac anesthesia. So, you teach them, they don't get enough of it in school, but they get a taste of it, and then when they get out, you partner and you have mentorship. So that's really important.
But on the flip side, my senior partner told me early on, every heart surgeon has to have someone who's willing to shoot him in the back. Because the problem can be that our egos are so strong that we don't know when to quit. The man who was his teacher kept operating until he was 80 plus years old.
Oh, wow.
And it was clear
Wow.
that the decision making was not right. The technical skills weren't going. His eyes were going bad. But his name was on the building. The hospital was named after him. And, you didn't tell him, listen, it's time for you to quit. Eventually, he developed an aortic valve problem. The guy who was my senior partner operated on him and replaced the valve. Post-operatively, he got an infection or something like that. But it was something that clearly would not allow him to continue to do heart surgery. My senior partner, when he got older, developed heart disease. And I had to operate on him.
Oh, wow.
So I shot him in the back. He did well with the heart operation, and he's still, I communicate with him now, and he's in his 80s and has been retired for 20 plus years and enjoying life. But he realized that after he had heart surgery, he just couldn't do it anymore. There's something, the eyes weren't there, the hands weren't working right anymore. So you have to have someone who supports you in the beginning of your career,
Yeah.
but you also have to have, hopefully, someone at the end who will be honest enough with you to say, take you aside and say, listen, this is it. You
Yeah.
can't do this anymore.
I mean, it's a very challenging job and has so much responsibility. I can imagine, maybe for other jobs we can do longer, but for something like that, yeah.
But we're also so egocentric. I mean, to become a heart surgeon, I mean, you're sort of selected out from everyone else who goes into medicine as being the cowboy. And as I said, it's incredibly fun to do. I would still be doing it nowadays if it were possible. But I realized when the time was to quit.
And so to conclude, can I ask you what made you decide to go into your respective fields?
For me, it was just by chance. I was a nurse and I was working in the heart unit, and these people would bring, anesthesia people would bring me the patient. And when I found out that was a nurse, I'm like, are you kidding me? That looks like the coolest job. And so a lot of people that come through our program, they all, are like, oh, I've always known I wanted to do this. But for me, it was just a chance, just by seeing someone bring me a patient. I'm like, this is the coolest job I've ever seen. And honestly, it has been for 30 years, been the coolest job. So that was it for me, is by chance.
For me, I graduated medical school in 1977, and modern heart surgery was in its infancy then. We still didn't know the answer of how to do a lot of certain things, especially the pediatric, the kids surgery. So it was a time in which new things were being done. Clearly, the cardiac surgeons were the technical wizards. I mean, you went into it because you were technically the best. The only reason I was good is, for some reason, I have incredible hand-eye coordination, or I used to. So that kind of selected who went into which field and where. And at that time, heart surgery was fun, it was exciting, it was busy as can be, and in all honesty, it was incredibly lucrative. Nowadays, a lot of the things that we used to do as heart surgeons is being done other ways, percutaneously by the cardiologist, putting little balloons or stents, or even replacing valves is being done without needing to go through the formal surgical approach. So a lot of the world that cardiac surgeons used to occupy has been taken away, and probably rightly so. I think, there's a lot of things that have been improved in terms of taking care of people at a lower risk and a lower involvement than traditional heart surgery. So I just happened to be in at a window of time where it was really, really fun, really lucrative, and I don't think I would advise anyone to go into it today.
I see. Well, thank you so much for taking the time to talk to us, and also for your contributions over so many years to the patients, their families, and from knowing you personally, I know that's something that you really care about, are the patients and their well-being. So thank you.
Thank you.
Thank
You're
you.
welcome.